Hello, everyone. I was about to say good afternoon, but realized we have attendees from several time zones, so I'll leave it at a hello. My name is Peter Manoogian, and we're here today to share our perspectives on the provider experience in value-based care, and specifically some ways for health plans to better engage providers to drive better member health at a lower cost. We'll start with some brief introductions and quickly touch on our learning objectives. So as I mentioned, I'm Peter Manoogian, and I'm a principal with ZS Associates and a leader in our health plan and provider industry practice. And ZS is a global consultancy with a deep focus in healthcare. And for the past 10 years, I've advised national and regional health plans both acquire and retain members and also facilitate a shift toward value-based care using data, insights, and analytics. I'll turn it over to my co-panelists, who I'm really excited to have with me here today. Tabasum?
Good afternoon or good morning. Peter, thank you so much for including me in this conversation. I'm really excited to join in and bring the provider perspective to our chat. Insights that I've gained both from my current role at the American College of Physicians, as well as having served as a medical director for a large population health plan.
And Jeb?
Hi, everyone. My name is Jeb Dunkelberger. I am the current head of growth for Notable Health, which is a digital clinical assistant. Formerly, I was the vice president of innovation, overseeing value-based initiatives at Highmark, which is Blue Cross Blue Shield of Delaware, Pennsylvania, and West Virginia, and also the second largest integrated delivery network in the United States. And today, I will be bringing forth a number of perspectives from both the provider as well as the payer landscape.
It's great. Yeah, and really happy to have you both here with me today. And so what we'd like to do today is accomplish three things. First, discuss, validate the headwinds that prevent providers from really engaging and thriving in value-based care, and also affirm why COVID-19 makes it all the more important for health plans to play a large role here. We'll also share results of a recent study that ZS commissioned on the provider experience in value-based care and how it reveals that health plans have a significant opportunity to really improve the support that they provide to their provider partners. And finally, we'll discuss that impact of improving the provider experience for both health plans and providers and share ways to get started through some vignettes as well as real life experiences. So the concept of value-based care is not new by a long shot, and there's been substantial progress in U.S. healthcare moving away from a purely fee-for-service system. That said, I'm not sure anyone is particularly satisfied with where we are today. In the chart here, it shows data based on the Healthcare Payment and Learning Action Network, and this is a public-private partnership that's comprised of payers representing 3/4 of covered lives in the US. And HCP Land created this framework to measure progression toward alternative payment models and measures its success on a yearly basis. The categories on the slide, on the chart, show a pathway from a purely fee-for-service model, category 1 on the left, all the way to more advanced alternative payment models, such as shared savings and population payments, or categories 3 and 4. And this is commonly referred to as a glide path by many. And the chart shows the percentage of healthcare spend tied to each category for HCP Land's first measurement year, calendar 2015, and the most recent measurement year available to us at the moment, calendar 2018. And certainly there's been a noteworthy shift toward the more advanced categories to the right-hand side during the 4 years of measurement. But 2018's results still fell short of that 50% goal on the right-hand side that HCP Land set at the organization's inception. More importantly, shifting healthcare dollars across categories might represent progress, but ultimately the aim is to improve healthcare value and quality. So why aren't we there yet? We see 3 reasons. First, there's a strong opportunity for health plans to have a much more specific vision for success, not just the proclamation around 2 million members tied to VBC programs by 2025 might be a nice rallying statement, but having more concrete steps to get along that path is really a difference maker for plans. And given the goal is bending the cost curve while maintaining or raising quality, volume numbers alone might not be sufficient. Second, and where we'll spend the most time today, is around provider buy-in. So we'll dive into this a lot more deeply as we go. And finally, there's a lot of difficulty measuring impact of the VBC programs that are out there. In many cases, this takes not months and not just a year, but in many cases, many, many years, given all of the complexities and attribution challenges. And so that absolutely kind of weighs on this transition. And so, Jeb, I want to turn it over to you. In your experience, how does this resonate with you?
Yeah, thank you, Peter. As you look at category 1 in the fee-for-service drop from 62% to 39%, I do want to call out the fact that some of these numbers can be a bit misleading. There is not uniform consensus in the market today in terms of how different payers are capturing the total percentage of fees that are attributed to value-based reimbursement, capitation, total cost of care, and just fee-for-service. And what I mean by that is if there's a metric contained within a value-based reimbursement contract that is for total cost of care, then oftentimes payers will count all of the money included in that total cost of care as underneath a value-based contract. The problem with that, though, is that the actual value-based payment may be less than 5% of the total revenue that the provider is receiving. So although it's a bit misleading, I completely agree with the fact that we are seeing a dramatic shift from fee-for-service to value-based reimbursement. As you shift to category 3, I think it's really interesting to look at that kind of shortcoming that we see with that 50% target. And again, this isn't surprising to me. What we have found is that a number of providers across different types of organizations, from large hospital systems to just onesie-twosie groups, are struggling to continue on that progressional path to that glide path. And the reason why is because, again, they feel a lack of support, and that for that, they cannot buy into these broader programs that are increasing risk, especially downside risk, on their organizations. So as you said before, provider buy-in and experience is definitely the number one thing that we need to look at today.
That's great. Yeah, thank you, Jeb. And let's cut right to that. So we'll give you a brief view into that provider VBC experience. We talked about provider buy-in as a category, but let's kind of pick up or pull apart those sources of provider buy-in. And there's 3 themes across the categories on this page. First, as we've engaged with providers collectively, there's a lot of frustration with the design of programs. Some providers feel like the measures aren't truly linked to patient health, or that they can't control them, or when they can, the goals are just too unrealistic, or the measurement of progress is unfair. There's also frustration with how the plan is communicated. In some instances, it leads to poor understanding of the program, or perhaps why some of the measures selected do matter. And this is very, very important in terms of incentives. If you're looking to drive behavior change, you need to have an understanding of what the incentive is and how to drive that impact. And finally, as Jeb mentioned, there's broad frustration with how health plans are supporting providers. And maybe some of you in the audience have heard similar feedback to these quotes. But I also like to turn it to Tabassum to shed more light from her perspective as to why this might be happening.
There's a lot of reasons. And, I think paramount to keep in mind is that physicians, providers, and practices often feel very isolated in this transition to value-based care. While they may embrace the overall concept and they aspire to make the necessary changes, they often have to make a go of it alone. And during the transition, these providers have to juggle patient care in order to optimize their practice's performance with one foot in 2 fields. They're in a fee-for-service, and concurrently, they're trying to adapt to the value-based care model. And they often feel that the clinical and financial measures of success are dictated to them by health plans. and they feel that there's little to no opportunity for them to collaborate in these selections of these measures. Then providers just feel like they're continuously swimming against the current towards an unclear target, and often, even if they're able to get there, the target's been moved. And so, when you look at the situation through this lens, it's not difficult to see why there is low provider buy-in. I'm not surprised at all by the findings of your survey.
Thank you, Tabitha. So with that in mind, we really wanted to take this limited buy-in concept and expand upon it further by hearing the voice of the provider. And to do that, we recently conducted an extensive study that included phone interviews with provider executives, as well as over 1,000 online surveys with PCPs nationally, which I believe might be the largest VBC-focused research on such a critical role in healthcare, the primary care physician. And the aim, as a result, was to go really deep with one specialty to get into some of these nuances around that experience. So our research focused on 4 topics: awareness and interest of value-based care programs, the barriers and drivers to participate, and for those participating in value-based care, what's working well and maybe not working so well, and then finally, how health plans are supporting providers during that transition. What's happening today, what's missing, and what kind of impact does that have on their experience? The respondents were cut across the United States, and in terms of a profile, about half said they were involved in some type of VBC program. And for our purposes, that includes fee-for-service with a link to quality or value, so that pay-for-performance category 2. The profile summary or the settings spanned across different types of practices, but there was also a substantial percentage of those who participated who had a decision-making role in health plan contracting. And given the size of the study, we were able to collect meaningful samples for all plans with a national footprint, as well as a half dozen state-based and regional Blues plans. So the overall research results point to quite an uneven picture of payment transformation in the eyes of the provider. And first, I'll start with awareness. So the chart on the left shows the PCPs who reported high awareness for the various payment models. And perhaps unsurprisingly, the models with the greatest awareness, pay for performance and capitation, were there and for 2 different reasons. So first of all, on pay for performance, that's typically one of the entry level or initial plans along that glide path. Capitation is highly aware for a different reason, because it's a much simpler model to explain in terms of reimbursement, but also it's very prevalent in government programs such as MSSP. What's interesting is those models in the middle, such as shared savings and shared risk, have a little bit lower awareness. And as we think about engaging providers in downside risk contracts, it might be very, very possible that just the lack of understanding and awareness is impeding their ability to move in that direction. So Jeb, any perspective as we're looking at some of these results?
Peter, as I look at these results, unfortunately, I'm not really surprised. I think there's really 2 important things to call out here. First and foremost, in terms of the awareness, the reason why I'm not surprised is oftentimes payers will contract directly with the billing entity for the value-based contract, and that could be a single signature. Underneath that billing entity could be 10, 20, up to hundreds of different providers. And so although the payer may feel as if they've made the billing entity aware of that value-based contract, that does not necessarily mean that it's trickled down to each one of the providers. And I think you've discovered that today. Similarly, there's actually literature that was out a few years ago when macro was first introduced. And it was quite scary that 1 year after macro was announced from CMS, almost 65% of providers were still unaware of this. And as you know, macro had a number of different pieces that had massive impacts on primary care providers.
Yeah, it's a great point. And so again, still a lot to work on in terms of driving awareness. I want to move to the right-hand chart very quickly. The percent of revenue expectations were fairly in line with what we've seen in other studies, but PCPs absolutely expect that shift to value to continue to occur over the next 5 years, with 50% of revenue expected to be there. So while awareness might not be as high as we would like, PCPs know where that payment puck is going. What's more interesting is when we asked about some leading indicators for impact. And on the bottom left, we asked about interest in future VBC participation. And surprisingly, only 1 in 3 indicated they were highly interested in continuing to participate in these programs into the future. And this is a lot lower than that 47% current participation rate we saw on the prior page. So it makes us wonder, is there a feeling that providers are doing this and they know they have to move to value because it's being forced upon them by the health plans, as Tabitha mentioned earlier? That seems like that's the case, rather than because they want to do it. And it also might be because their current experiences with value-based care programs is just okay, which is what that middle number shows, a satisfaction rate on average of 4 out of 7, which is just, again, middling. And this satisfaction was rated at a health plan level. National plans, regional plans, all were in that same zone, basically. You might have seen some local plans perform a little bit better, but there's still a lot of room to grow. And the bigger concern for us, however, is the final stat around impact. Only 1 in 9 surveyed said that they were engaged in a value-based care program that was highly impactful to the way that they practice medicine. And so just think about that. It means while payment transformation is well underway, clinical transformation in the eyes of the provider lags far behind. Our next step was to really understand why that was. And we looked at a variety of aspects to that value-based care experience for PCPs. But the most compelling finding around impact had to do with the level of support that PCPs felt PCPs felt health plans delivered. Interestingly, an overwhelming majority, 92%, said that they desire health plan support in their programs. They absolutely want it. But only 1 in 3 said that they are receiving the desired forms of support through VBC. And that is a big misalignment. And if you look across the categories on the bottom of the page, there are some services, some support resources that are under-delivered, such as stop-loss insurance or administrative support. And then there are some that are over-delivered, such as peer comparisons and population health data. And so this is leading to a suboptimal experience for PCPs. And so, Jeb, in your experience at Highmark and elsewhere, what support has been given to date, and what's been most impactful?
That's a great question. Because boy, there's a lot of support that's been deployed into the market, and I think there's been some tough lessons learned. First and foremost, you have to start with the reimbursement. The reimbursement has to be there. There has to be a financial incentive in place to move forward. On top of that, analytics have been deployed, these actionable insights. But with analytics, these are all claims-based analytics, right? So they're always lagging 3 to 6 months. Additionally, technology has been rolled out. Typically, this has been point solutions and usually slanted towards the payer that is also offering that technology. People, boots on the ground, clinical transformation consultants have been rolled out by Highmark, and we've also seen a number of other use cases across multiple payers in terms of putting people into practices to help with those transformation efforts. And then finally, I think payers have taken some pretty big steps forward and actually acquiring, owning, and employing those provider groups. And you see that with integrated delivery networks. You see that with a lot of the large consolidation plays and even groups like Optum Care that have really shown different models for rolling that out. In terms of what's been impactful, I'll tell you what, value-based reimbursement is definitely needed, but actually financial downside risk that is performance-based, not actuarially based, but performance-based, is really important. There definitely needs to be elements of downside risk that at least have been shown to be effective. A payer-agnostic platform. So you cannot roll out a platform that is slanted towards the payer that's offering it, but you have to think about the provider who's using it. It must be payer agnostic. Also, workflow solutions, right? So oftentimes it's not just people and technology, but it's the workflow itself. Adding more to the workflow adds more time and more effort. And as we know, providers already are maxed out. And we see that through countless studies, right? And so for us, workflow neutral solutions must be deployed. And then finally, real-time analytics. So it can't just be actionable, which means it's very simple, straightforward, and you can make a decision off of it, but it also needs to be near real time. And that way, when you're in the fourth quarter of the game, you're not using halftime's data to make decisions. And all of that should be able to culminate in allowing providers to be more successful, more supported, and feel better experience with their value-based journey.
Great. Yeah, and that's excellent insight, Jeb. And Tabassum, I want to turn to you. How, from a provider perspective, how does this all sit with you?
I'm not at all surprised by the reactions of your respondents. Health plans really need to consider looking at their support strategies with in a Goldilocks approach. What I mean by that is not too little information, not too much, just the right amount, and delivered at the right time and at the right depth. Sometimes I've seen, just as your respondents are telling us, that tons and tons of reports and information get dumped on practices. But it's worth recognizing that a large quantity of data is not equivalent to high quality, actionable data. Practices are seeking tailored information that's easy to understand, and more importantly, is going to easily lead them to make effective changes with ease.
That's great. Yeah, and echo your point that all of these support resources are desired by segments of providers, but not everybody. And so this idea of really making sure we're aligning appropriately will go a long way. So there is a glimmer of hope here, because we said that about a third of providers feel like they're receiving their desired forms of support. And so there's strong impact when that occurs. So to move to that, we asked some questions around interest, feelings of support, and feelings of trust. So all of these are really positive indicators around VBC experience, as you would imagine. And what we're showing on the page is the comparison of the 2/3 of providers that didn't feel like they were getting supported appropriately versus the third of providers in green that were. And the impact on all of these indicators was statistically significantly higher. And this has a real benefit for plans, especially because it correlates to providers' willingness to stay in VBC, but also take on more risk. So as an instance, we asked about the willingness, how much risk you were willing to take on in a downside contract. And those PCPs who were highly trusting of health plans were willing to take 2 to 2.5 times more risk than those who weren't. And so as we think about moving providers down that glide path, driving that support alignment seems like a really critical piece. So the question becomes, how do we do this? And recognizing that importance of building trust with providers through a better experience, a mindset shift might be required. And with that in mind, we're sharing a couple of universal truths. The first one, each provider is different. And that means we have to approach each provider differently, which we'll talk about. You're like not the only health plan or payer engaging with that provider. And then finally, exposing providers to more risk, that doesn't equal practice transformation. That alone can't be the vehicle. And so we can't confuse actuarial risk with performance risk, which we'll talk about. And so how you set yourself up with providers is the secret sauce. And so Tabassum, I'd love to turn it over to you to talk about a couple of these mindsets and what that might mean in terms of a health plan.
Absolutely, Peter, you're on the right track here. I do think that health plans are going to find it worthwhile to put in the effort to cultivate a deep relationship with providers. They need to orient themselves towards building a long-term and trusting partnership. And health plans are going to enable success if they approach providers and practices with an uncomplicated, respectful, and inquiring approach. They need to start with an acknowledgement of the challenges facing practices today. And it'd be great if they could lead with a commitment to not create more administrative burdens. That alone will go a long way towards facilitating the shift towards value-based care. And we've been talking about this glide path to value-based care, and I definitely agree with you that it should contain health plan support. But health plans should remember that the glide path needs to be of sufficient length and sufficient depth of support and resources so that practices don't find themselves floundering before the transition to value-based care is successfully achieved. So lead with respect and really build that trust with a long-term mindset.
Excellent. Yeah, and Jeb, we've talked quite a bit about that long-term view around glide paths. So, and anything to add here?
Yeah, there's a few things. First off, glide paths are typically, highly choreographed plans over 3 to 5 years, right? But where they fall short is they oftentimes only consider the reimbursement methodology and don't begin to also talk about the experience and the support that's going to be required from the providers. I think it's also important that from a payer perspective, anyone that's living and breathing this every day understands that each provider is different, not only in their maturity, right, in their ability to manage different types of value-based contracts, but also in their panel size. So some providers could have 40, 50% of a commercial plan, where others have 5 to 10%, right? And so managing, that plethora of payers is also very difficult. And, as we call out here, recognizing that performance risk, should be separated from actuarial risk. I think one of the big things here in terms of experience is that providers want to feel like they can control the outcome, right? They don't want to manage actuarial risk, which is really the job of the insurance company. And they want to manage what they can control, which is performance, referrals, and things that relate to their care management and day-to-day lives. And so I think you do an excellent job here posing the question that experience should be built into the glide path approach that they're currently rolling out when it comes to reimbursement methodologies.
Great. Yeah, and I'm glad we're kind of honing in on this experience glide path concept, because we really want to move forward into what do we do as a plan. So if we're buying this notion of provider experience being critical, how do we take those steps? So with that in mind, I'll turn to that. And from our experience, the health plans who have adopted this experience mindset, they take the following steps. And I like to call this the quadruple E to achieve the quadruple aim in value-based care. And the steps include, first, considering the health plan's context and objectives. Then, more deeply profiling providers through integrating both health plan and external data. And then engaging through really tailoring those support mechanisms to make sure we're hitting on exactly what providers need, as Tabassum said, no less and no more. And then finally, really evaluating the impact, and not just reactively, proactively, by getting into some leading indicators and really determining what that needs to look like. Now, none of these steps on their own are revelatory. And many health plans are doing this, but we've found that there's a challenge that these steps can occur in silos or not linked together like this in the context of value-based care. So rather than talking about all of them in detail, let's go through each of them one by one with some examples. So that first step, as we talked about, was determining the context in the unique situation of a health plan. So this includes many categories to consider. Now, on the left-hand side of the page, there are some environmental categories. These are geography, the lines of coverage affected. So a VBC program around Medicaid members might require different needs from a provider perspective than a program that's heavily focused on commercial lives. The provider type or types involved in the particular program might also have an indication on what that experience needs to look like. The right-hand column focuses on attributes of that VBC payment model. So the first of all, the payment model type, that might lead to different needs. And then that payment stage. And so by stage, we mean the place in the program life cycle that best matches the situation. Now, for instance, is a plan about to launch a new contract with a provider or providers? Are they in the process of launching in that initial period of months? Or are they in that second to third year along that multi-year arc that Jeb just talked about? And of course, the plan's objectives vis-a-vis that program should be considered as well. And so I'll share a recent example from a health plan conversation I had. Plan has presence in a few states, and they were considering entering an ACO with the hospital system. And it would have been their first ACO ever as a plan, and they were about to launch. So they hadn't done an ACO before, and they weren't really sure about the buy-in, at the levels beneath the executive organization. So the practice management and then all of those frontline providers. And so their engagement objectives were much more focused on the early aspects of engagement, understanding the stakeholders and their influence, their levels of buy-in, and then determining where they, the plan, could play a role in driving alignment through strong change management. Once the context is in place, defining objective ways to measure provider experience becomes a bit more clear. And so in this instance, consider an example from a PCMH program. There's an experience index that is a composite score of several different attributes. There's forms of interaction, both with those boots on the ground, but also with clinical and digital content. And then there's forms of interaction around sentiment in terms of how they feel about the program and how engaged they are. And then, of course, there's behavior change, perhaps changing referral patterns to high quality specialists. So each of these sections could have a different weight, and those weights could vary over time depending on the PCP's tenure in that program, similar to the glide path concept. The next step is around really making sure that we're using the data both in-house and at our disposal to our advantage. So in today's world, health plans have a wealth of data at their disposal, but it might not tell the full picture of a provider. And it's also quite possible that that valuable information sits in different parts of the organization. It may not be used always for driving purposes of providing a great VBC experience. And so this narrower lens leads to some of those gaps that we talked about earlier, where only a third feel like getting the right support. And so the opportunity to enrich provider understanding is absolutely there, and it can be done through several third-party data sources that can shed on categories at the bottom left of the page. And these include the current risk contracts the provider is engaged in across payers, quality performance compared either at the state level, regional level, or nationally, or even by urban, rural settings. The provider's ability to influence physicians, especially important for larger practices and hospitals. And then finally, IT sophistication in terms of data sharing capabilities. And pulling this information into one succinct package, like we have here for a hospital in Arkansas, and then integrating that with plan data can serve as an asset when both determining the engagement and reimbursement strategies that best fit the plan and provider's needs. All right. So the profiling step on the provider page, or the prior page, serves as an input into developing segments to better tailor the way that they engage with providers as we carry forward the attributes from the profile. So this example shows how different combinations of ratings might lead to different engagement approaches. While we have some examples on the page, it's important to note that each plan, likely has a library of initiatives and support resources to offer to plans. And as we've been saying, it's a question of who needs what and when. Another thing I wanted to hit on was this notion of, engagement journeys and engagement approaches. And so we have a couple of examples on the bottom of the page, but I'd love to turn it over to Tabassum to talk about a couple of these in her experience.
Thanks, Peter. Several examples come to mind right away for the education clinical guidance component. I've seen several excellent learning collaboratives where providers have come together and they've been able to share experiences in a peer-to-peer setting, and they share best practices. And it has a lot of power because they are speaking the same language. They are sharing good examples of improvements that are based in reality, and one physician or provider can really identify with the learnings of another. And the guidance can be both clinical as well as sharing best practices, for example, in forms of workflow enhancements that one practice can then apply back at its own office. For example, in patient management and patient guidance, I've seen some great examples where health plans have been able to complement and supplement practices' efforts around chronic disease management. Patient education is just so time consuming, and it needs to be delivered in small, repetitive doses. Sometimes it's just beyond the capacity of a practice, but a health plan can come in and sort of pick up the slack there and take some of the burden off of practices by offering remote patient education, for example. And sometimes that's really a wonderful complement to what the practice can do. And the ultimate winner is the patient because they receive ongoing education to improve their chronic diseases.
That's great. Yeah, and Jeb, I know you had some experiences to share around some of the other engagement methods.
Yeah, it's been really interesting. From a tech enablement perspective, I've seen investments everywhere from helping providers purchase electronic health records all the way to helping them redesign their entire workflows. I can speak on behalf of Notable as well as Highmark. I currently have a contract with a payer right now where we are working with a number of their providers within their network, helping on workflow redesign. And so we think that there's a number of different plays that we're seeing in terms of tech enablement that payers are really willing to do. But I think the most common thing is you actually see technology investments. Knowing, again, this needs to be payer agnostic, I think a number of payers have kind of caught the cue that providers need to be able to plan for multiple payers. Again, the strategy and the planning behind that is a little difficult for payers, but at the same time, you have to think of the practicality for the provider. In terms of consultative support, there's a ton, right? And I think at the highest level, you should start with the advisory groups that a number of payers have pulled together. So if it's the hospital advisory councils, provider advisory councils, or even as we were just previously talking about, these peer or specialty specific advisory councils, which help inform the payers on exactly what should be rolled out from a value-based perspective. As you kind of drop a level down, consultative services really take the form of people actually coming in and helping these practices. So as I said before, clinical transformation consultants have been used to go in on behalf of the payer and help those providers from a consultative perspective. And then finally, I think that there's a lot of co-designing, right? And so a lot of payers meet the providers where they are, and they sit down and they co-design the program and that glide path with them. I think ultimately the most important point to take away from a slide like this is that payers and providers, despite everyone's thoughts, are intimately aligned, right? They want the same thing. No payer wants to see a provider end up in a tailspin due to a value-based contract that they developed that had too much risk and required too much technological advancement for that actual provider to execute on. So I think that's important to underscore when you look at this slide.
Got it. All right, great. Yeah, great input in terms of great examples. Appreciate that. So I'm going to hit this page relatively quickly. The final step is around evaluating the impact and measurement in terms of experience. And so on the left-hand side of the page, health plans absolutely know who their top performers are in VBC programs, whether the metric is a composite HEDIS score or whether it's improvement over a benchmark or total cost of care reductions over time. Your top performers, like a bell curve, you'll have some top performers, you'll have some bottom performers, a lot of providers in the middle. But what if that experience index that we're talking about could help proactively explain differences in quality improvement or in performance? So experience can become a causative driver of performance rather than something that we look at after the fact. And so there's absolutely many ways that plans can begin to get on this measurement path. It will be unique, as we've said, by context and by plan and by stage in the VBC life cycle. But it's something that we absolutely see as a critical step here because it will help redirect future investments and paint the picture for why the support that we're providing is so valuable. So in closing, we have a few takeaways to share. Well, first, it's reminding ourselves that if you've engaged with one provider, you've engaged with one provider. Now more than ever, plans are looking for, or providers are looking for health plan support to succeed in value-based care. And a one-size-fits-all approach is both costly and ineffective in building provider trust. Next, the experience that you deliver to providers is absolutely critical. And that's why we feel strongly that health plans should consider that experience glide path that are targeted for their unique context. And if you're not delivering an amazing experience for providers, then somebody else will, which could put you at risk. And third, go beyond your internal health plan data to get a broader perspective and picture of the provider. And there are ways to do this so that intelligence can be built at scale through using third-party data sources, enabling your organization to focus on engagement versus simply just understanding. And finally, measurement. So define and measure, what that experience is going to look like. And the more objective, the better. So I do want to turn it over to Jeb to talk a little bit about some final points. And then, time permitting, I'd also like to ask Tabassum to share some of the more recent research that she's seen from a COVID perspective with her providers. And actually, maybe we'll start there. Tabassum?
So it's so interesting how the world has shifted and changed in the face of the COVID pandemic. There was a study done in mid-May by the Larry Green Center in partnership with the Primary Care Collaborative, and the results are very telling. Over 700 respondents from 49 states took part. They represented specialties of family medicine, pediatrics, and internal medicine. And over 80%, an overwhelming majority, indicated that payments based on volume and extensive documentation negatively impacted their resilience during the pandemic. And 50% of these clinicians felt that predictable payments in exchange for transparent reporting on a small but essential set of meaningful measures was the key to current and future primary care practice sustainability. So they're in it. Primary care practices and providers totally understand and embrace the need to succeed in a value-based care environment. And I think it underscores everything we've been saying for the last several minutes, which is success is it needs to have a shared view. It's not just providers succeeding, it's not just health plans succeeding. Success will happen when both succeed together. And they need to be ready to partner respectfully to make that success happen.
All right, well, that is everything we had today to share with you. We really hope you enjoyed the conversation, and please don't hesitate to reach out to any of us if you have any questions or want to continue the dialogue. Wish you all a great rest of the conference. Thank you.